Hi everybody, you can hear me okay? Thanks for having me. Thanks for coming by. Appreciate the turnout. We're going to talk about brachycephalic obstructive airway syndrome. How many folks here deal with these cases at your practice? Fair number, okay. How many of you folks who see these cases operate on them? Okay, a couple. Okay, cool, great. How many folks, when they get these cases, are terrified of them or frustrated by them? Okay, a lot on that head nodding. Thank you, Zomedica, for sponsoring this event. Much appreciated. A little bit about me for folks who don't know about me. I graduated from Cornell University in 2006. I then followed that up with my one-year internship at Angel Animal Hospital in Boston, in the US. I then went through my surgical training, so I'm a board-certified small animal surgeon. After that, I flew around the country in the States, and then I opened up my own telehealth platform called VetTriage. So this is the outline of what we're going to go through today. I do have proceedings for this. If you don't have proceedings yet, and hopefully after the show, I'll bring it to the London Vet Show to share the proceedings. But basically, my notes on this are very, very thorough. Lots of detail. It's almost academic. The point of this talk is to make it clinical, practical, hopefully information you can use at your practice. But the more didactic stuff will be in those proceedings. So we're going to go through the definition of this disease, pathophysiology, how GI disease relates to it, clinical signs, diagnostics, medical management, surgery, post-op monitoring, complications, outcome, prognosis, and any key points that we have for the lecture. Regarding monitoring, I will go into some fair detail about this because telediagnostics are already here. They used to be in the future, now they're here. And so telediagnostics for cases like this might help with some of your frustrations with managing these cases. So we'll spend a fair amount of time with monitoring as well. But anytime you folks have any questions, feel free to interrupt me. I'm happy to stop and answer any questions you have or any comments you have as well. So by definition, this syndrome is exactly what that is. A syndrome has multiple components to it. And so this is just the more common components, but there are many, many others. Elongated soft palate, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, and laryngeal collapse. And even tonsils I'm thinking about just getting rid of because I never remove tonsils in these dogs anyway, but because it's reported in the literature, I want to make sure that you're aware of it. But these are the most common conditions that you see with this syndrome. So what we believe with these dogs is it starts with the stenotic nares. If the nares are stenotic, then that leads to everything else downstream regarding the airway. So that's why when you see these in younger animals, the recommendation may be, if the parameter is up for it and you're comfortable with it, or you're going to refer, to repair these at a young age. Theoretically, we don't know for sure, but theoretically, if you repair the nares at a young age, you hopefully are going to prevent all the secondary changes to the respiratory tract and cardiovascular system that are going to happen over time for these dogs. The problem with any kind of preventive surgery like that is it's unpredictable. You may take a dog that would have been fine despite having stenotic nares and then operate on them, or you may have a dog that you didn't operate on that develops later on pneumonia, cor pulmonale, all these other diseases, and you wish you had repaired them. So it's a tough call, but the very small number of studies that are out there show that if you do repair the nares, you have a good chance of preventing everything else that comes after it. It's hard to say for sure though. So the idea is stenotic nares happens first, it's congenital, and then when that does, it starts creating an upper airway increase in resistance, and over time, the soft palate becomes affected by it. And so the soft palate, as a response to that turbulence in the airflow, ends up getting thicker, longer, bigger, and then that causes a contribution to the upper airway obstruction that we see in these dogs. Then from there, once the palate starts to enlarge, we then believe that the laryngeal issues happen. The everted saccules, which are right here in blue, start to become pronounced. Over time, the laryngeal walls become weakened, and you end up getting laryngeal collapse. And so the cartilages begin contacting each other, causing inflammation, edema. And then further down, once you go beyond the glottis, you'll end up affecting the trachea and the bronchioles. So it literally follows that trend. So once you have all the upper airway stuff affected, then lower down they'll be affected with lower airway disease. This shows you a CAT scan, computer tomography of a dog, just comparing the breeds, how insane it is when you have these normal shaped skulls, all that open airway, sinuses, and you have a brachycephalic where there's like nothing there, right? So nasopharyngeal stenosis is the problem with these animals, but you can see how dramatic that is. And then of course a gross depiction of it, I mean look at this pug's face. It's got no face to it. And then meanwhile you have more other brachycephalics that can be a bit more normal, but still considered brachycephalics. This is an example of a scoping procedure done, and these are the normal nasopharyngeal areas here, and these are caudal aberrant turbinates. So some of these dogs, some, not all, end up having turbinates that become more fleshy and pronounced in the upper airway. The problem with this is, other than maybe CT scan, but usually scoping, you will not know it. And as a surgeon, I personally don't look for these abnormalities. But the reason why I'm bringing it up is because you have to realize with this disease, it's multifactorial, and these dogs have lots of other things going on that you may not be aware of. And you may not be able to diagnose it depending on what you have in your facility. And then of course, radiographs are used to rule out other conditions, pneumonia, things like that. We'll go over radiographs later on. So GI disease, how many folks here recall seeing gastrointestinal disease with brachycephalic airway syndrome? Fair amount, yeah. And usually if you don't, it may be that you just didn't dive into the history enough, because these dogs frequently have concurrent gastrointestinal problems. So the thought with this is multifactorial. Megaesophagus, so local disease of the esophagus here, can be seen with these dogs. It could be because they're under anesthesia, that's one possibility, but the more likely possibility, if they have GI disease, is chronic esophageal reflux, esophagitis, and that'll create megaesophagus. You don't treat the megaesophagus like you would like a myasthenia gravis or something like that, but you wanted to be aware that this dog does have some kind of GI reflux. Obviously, the way to figure that out, of course, is the GI scope, but again, depends on, do you have access to that? Is it necessary? Is the dog in a respiratory crisis? You have to operate today? It's tough to say. Sliding hiatal hernias are a problem with these dogs, and the problem with hiatal hernias is that they're dynamic. You don't see them usually on a radiograph unless they're really advanced, where you just get lucky, I guess. But you need fluoroscopy to figure that out. And how many people here have fluoroscopy? It's not a common diagnostic modality. But sliding hiatal hernias are a problem. Gastrointestinal dysmotility is an issue with these dogs. This is not a GDV, this is a gastric bloat, but these dogs are prone to having gastric dilatation with gas and fluid in their stomach. And then brachycephalics in general are prone to pyloric stenosis. It's another condition. Now, is that related to brachycephalic airway syndrome per se? Maybe, maybe not, I don't know. We don't have that in the literature, but it is a disease that you see in brachycephalics. So gastrointestinal disease is a big problem with these dogs, and you would assume if you fix the airway stuff, that the GI stuff would get fixed as well, but that's not always the case. And we'll talk about that later on, how to deal with that. Clinical signs, we all know, you have the classic brachycephalic with loud breathing, open mouth breathing, drooling of various ages. Radiographs are a great screening tool. So I showed this just to show you that you can potentially see a palate on radiographs as well. I wouldn't use that as a diagnosis of elongated palate, but you can see this one in particular goes into the laryngeal area. That's a pretty long palate. This here is showing how you can measure hypoplastic trachea, and the proceedings I have with those measurements are. But typically as a surgeon, I'm just eyeballing it. Does the trachea look smaller than typical? But you can actually measure it as well if you want more objective information regarding that. And then finally, of course, thoracic, a lower airway disease rather. We're looking for bronchopneumonia, very common in these dogs. We're looking for other conditions too. Do they have heart disease? Is there metastatic disease? Can you see a hiatal hernia on here? So your radiographs are going to be crucial. I don't routinely perform skull radiographs, but 3-view thoracic radiographs I will perform in these dogs. CT is great if you have it, or if you refer the case to a surgeon and they feel as though it's indicated for that case. I typically don't do this on a routine basis, but I just wanted to show you that there are studies that look at CT scan, evaluating the nasopharyngeal region, and we even have a category list of the abnormal turbinates that we saw in that first picture before the scoping, so you can actually grade how bad the turbinates are. So let's say you have a brachycephalic that you've operated on and it's not doing that well afterwards, right? Well, it could be that it's developed secondary diseases that maybe you diagnosed or didn't, but it also could be due to other upper airway issues that you just weren't aware of. And so just be aware that these things do exist. Laryngoscopy, of course, is the key because we're looking to repair their upper airway disease. So we diagnose this condition pretty much by looking into the oral cavity, which requires sedation, of course. Now, what these pictures show here are different stages of laryngeal collapse. And just to backtrack before I go further here, when I talk to pet owners about this disease, I tell them I divide the conditions into things I can fix and things that I can't fix. The things I can fix, if your dog has them, we're going to try and fix them. The things I can't fix, if your dog has them, I can't do anything about. And so that sets them up for potential for post-op complications. If you have a less than ideal outcome, it gets the client understanding, well, you did tell me that there were some things you couldn't fix, and you did tell me, based on your tests, my dog has those non-fixable things. So for client communication, because this is a very complex disease, and you only have so much time in a consult with these folks, I break it down to I can fix some stuff, I can't fix other stuff. And so laryngeal collapse is a major problem because I can't fix laryngeal collapse, right? And there's different severities of it, and of course, the prognosis relates to how severe laryngeal collapse is. So when you talk about the stage of laryngeal collapse, stage 1 is when the saccules are everted. That's this picture here. So you can see behind the glottis that the saccules are puffing out. And I'll actually see this dynamically when I'm looking at the laryngeal area. They'll puff in and out, the saccules. Stage 2 is the saccules plus cuneiform process contact. So the cuneiform process here in this drawing of the arytenoids right here. They'll start to contact each other, and then as time moves on, you get to stage 3 where you have saccules, cuneiform process contact, and cornicular process contacts, and so that's when you end up with that area contacting each other. And you get these swollen erythematous arytenoids, and that contributes to the upper airway obstruction that these dogs are suffering from. Lower airway diagnostics, again, as a surgeon, I'm pretty much stopping at radiographs. However, if I have a reason to refer to internal medicine for scoping, then I certainly can. But just to remind you that these dogs not just have laryngeal collapse, but over time they can have hypoplastic trachea, which they're usually born with, but then bronchiolar collapse is a problem lower down. And then that increased pressure in the respiratory tract contributes to cardiac disease. And so they can have secondary cardiac disease from their chronic respiratory disease. We're all familiar with oxygen therapy. This depends on what you have at your practice. These are just different pictures of how we supply these dogs with oxygen. And then the rest of medical management is complex and variable and depends on what your comfort level is, depends on your experience level with this. So most of us, of course, are going to be reaching for our sedatives to try and control and capture this airway, right? And I use that to my benefit. I'm stabilizing the pet by sedating them so they don't continue with this vicious cycle, and I use the opportunity to do a laryngeal exam. And so I'll do that all at the same time. Typically, with these dogs, I'm giving propofol with my laryngeal exam to effect. The technician, the nurse, is titrating the propofol, I'm giving it IV, and I'm sitting there with the laryngoscope and waiting for the dog to be sedate enough that I can still see them actively breathing, but I can now have a good look at the laryngeal area. So I like a lot of propofol. Typically, if they're in a crisis, injection of ACE, and then induce it with propofol, and then I'm able to pass the endotracheal tube once I'm done with my laryngeal exam. Steroids are phenomenal, and I know we go through phases in our profession where we love steroids and hate steroids. That happens over years. That's a typical cycle, but steroids are fantastic. They lower the laryngeal edema for that dog, and I will frequently use something like Depo even preoperatively for these dogs. If they're in a crisis, pre-op and post-op, I will use it as well. And I typically don't repeat these injectable steroids more than twice. I'll give one injection. If I don't get the response that I like with these dogs, I'll give another injection like 30 minutes later. You have to worry about GI disease, right? It's a lot of steroids to give a dog. But if I'm trying to save their life, I'm okay with some diarrhea to save their life. So you have to balance those things. Obviously, drugs like prednisone or Rimedo are given with dogs that are able to take oral medication. But the idea here is anti-inflammatories. If you're not a steroid fan, you've got non-steroidal anti-inflammatories. In my experience, not as potent, not as fast-acting. So if you're in a crisis, my preference is some kind of steroid, whatever you're comfortable with. Now, I only bring this up for a couple reasons here. This surgery is considered a dirty surgery, right? So the sterility there is minimal to none. If you're going to treat them with antibiotics for whatever reason, beyond any complex case, I like Convenia. You guys have access to this? Yeah. Okay. So I like Convenia for these dogs because obviously injection lasts 10 days or whatever, and it's okay. It's obviously marketed for like dermal stuff, but if I want some antibiotic coverage for whatever reason, and I don't need anything that's like stronger than that, Convenia is great. If I do want to step it up a little bit, but I'm not getting too hardcore with antibiotics, I like Simplicep because it's once a day, so it's less oral administration of drugs for these dogs that already have gastrointestinal issues. But you don't have to treat these patients with antibiotics. Most of the time I don't. But if I'm going to, I usually try for these. Obviously, if you have bronchopneumonia, you're going to treat with whatever you feel comfortable with, whether you're doing broad spectrum or multiple antibiotics, whether you're doing injectable versus oral, it's up to you and the case. But for a routine case with no complications, if I'm going to reach for antibiotics, I typically am going for one of these two. Cerenia has grown popularity over the past few years. People are using it routinely as a pre-med. How many folks here use it as a pre-med, pretty routine for any case? A couple of people. So obviously the main goal with Cerenia is anti-nausea. You're trying to prevent regurgitation, vomiting in these dogs, pre-op, but especially post-op. So Cerenia is fantastic to have on board. And then I'm a huge fan of metoclopramide. Reglan is great. And I will actually give that as a pre-med, especially if on my thoracic radiograph I can see the stomach is full of food, but I have no choice but to go into surgery, right? So I want that food to move out of the system. So I'll give them an injection of Reglan at induction, and then sometimes if I'm really worried, I'll keep them on a Reglan CRI post-op. Reglan CRI post-operatively is cheaper, and I don't know if it's necessarily more efficacious, but it's more cost-effective for these dogs if you're going to have them on it. So I'm a huge fan of metoclopramide. I think it's great. And then temporary tracheostomy tubes. How many folks here have performed tracheostomies? Couple. Yeah. So there's more and more literature about doing this more proactively. I only use these in the case of an emergency where we can't capture the upper airway. There's so much laryngeal edema and collapse, it's just a mess in there. Most cases are not like that. But if you do have any reason, either pre-op for stabilization purposes or post-op if you're having issues, a temporary trach is great. A permanent trach is a nightmare. I've only performed one permanent trach. The rest of mine have been temporary tracheostomies, so I'm not looking to have it be a permanent tracheostomy. But you can use this to help stabilize the pet. It's not that difficult to do. You just have to have the right equipment for it, though. You need special endotracheal tubes and the cuff for it. But the rest of this stuff is pretty routine if you want to dive into that. I'd recommend a cadaver, of course, to practice with if you're going to dive into the world of tracheostomies. So surgery. Nasal resection, there's different techniques. I don't care what technique you use. Usually we're looking for, is it efficacious and how cosmetic is it? Because the pet owner is going to be looking at that dog's face and you want the nares to be symmetric and good looking. I find myself as a right-handed surgeon, I typically am doing the right side first and then I do the left side and now I hate my right side. And so I'll go back and redo the right side. So I'm fine with redoing my surgeries just to make it look a little bit prettier. But whatever technique you want to use is great. This is what you're going for before and after. So you can see those nares are opened up. Once you repair the nares, then set them up for brachycephalic surgery. Those of us who operate these dogs are familiar with this kind of janky setup. You're trying the best you can to get this heavy dog's head elevated, opened up. You've got a thick tongue, endotracheal tube, gauze, everything's in your way. It can be pretty annoying, but the setup, you want the setup to be as comfortable for the surgeon as possible so that you don't get frustrated by it. So however you have to redo this, go for it. But this is a pretty typical look for this type of surgery. So first I repair the nares, and then we set them up for the upper airway surgery. So for the palate resection, elongated palate resection, how many folks here are using some sort of cautery device to do this? A couple of people. How many folks are using laser? Yeah, okay. And then how many folks are using suture? A couple. Okay. So I used to do suture when I was training as a resident, and then when we were able to get LigaSure or some sort of bipolar cautery sealing device, this is phenomenal. Now, those of you who repair these dogs know that some of these palates are so damn thick that even a LigaSure like this, it won't be strong enough. So you have to go to more old school measures, well either laser, which I'm not that familiar with, or suturing. But if the palate is not that thick, then I love these devices. I mean, this made the surgery go from like 30 minutes of frustration and sweating and trying to work in a small cavity to like a couple of minutes and it's done. I love LigaSure. So it has to be worth it for your practice, of course, to have one, and you have to use it on the right case, but that to me is phenomenal. Otherwise, the suture technique or laser, depending on what you want to do. Now this picture is a bit extreme. This is showing the staphylectomy, removing it, and then the dissection. You want the very tip of the palate to just barely contact the tip of the epiglottis. That's your marker for this. This is a very extreme picture. I don't know what's going on there, but you want to make sure that it's touching the epiglottis tip a little bit. I would prefer to keep these on the longer side than too short, right? You can always remove more if you need to, but if you remove too much, that's it. That's what you've done. So I will err on the side of it's a little bit too long if I'm not sure. Now here's the big thing with this. Let me see if I have. Okay, here's the big thing here. Like we said in this photo, you have all this stuff in your way, right? So what I will typically do, because when you open and close the mouth, it changes the palate, and when you have the tongue pulled out, it changes the palate, and you have an endotracheal tube in place, which also will alter the anatomy. So you want to find the most natural airway, upper airway that you can with these dogs before you make your cut. So I will actually constantly lower and lift their head. It's very annoying for the nurses, I get it. I will actually extubate them and try to plan where I'm going to make my cut. I want to see the most natural position for this palate that I possibly can. That's what I'm looking for. So I will extubate them, leave the tongue alone, eyeball it, open up again, move the tongue, see what the palate's doing, and keep reevaluating before I make my cut. So keep that in mind too, because an easy way of making this palate too short is you don't modify the anatomy, you're going based on just an open mouth, an opening, and you cut, and next thing you know, it's too short. So make sure that you're playing around with the anatomy here before you perform your cut. And then also with that, because you're going to extubate them temporarily and it will take you a little bit, I have propofol on hand. So the nurse can titrate propofol as needed, so we can keep the dog sedated while I'm trying to figure out where I want to make my cut. Everted saccules. Over time, I've been going away from removing these. I will tell you that some of these dogs, when you do the nares, you do the palate, and then I re-look again at the saccules, and the saccules are pretty much gone or improved. And so I've become more conservative with these. So lately, I haven't been removing them as aggressively, but you wouldn't be wrong to remove them because they are abnormal. It's just that if the increase in airway resistance contributed by the nares and the palate is gone, then I've seen these dogs just improve with their saccules. So I'm not a big advocate, I guess, as much anymore, but if you want to remove them, you can remove them either with sharp dissection, you can use cautery, and so there's the LigaSure being used there, but the everted saccular surgery otherwise is pretty straightforward. Now, this is for the stuff that we can't fix. So I just want to throw up some ideas here. Because I've seen this done before for cases of hypoplastic trachea, right? Where you did the surgery, did the routine surgery, dog's not doing well. Maybe you have to go back in and do a partial retinoidectomy. Still not doing that great. You know they have hypoplastic trachea. So do you place a stent or not? And I don't know the answer. I've seen it done as a life-saving measure, a Hail Mary, right? Theoretically, with the hypoplastic trachea, it's different dynamics than a collapsing trachea. Collapsing trachea has soft cartilage, it's dynamic. Hypoplastic is just small. And I'm not sure how much improvement you'll get with placing a stent there, because it's not a dynamic collapse. But I'm just throwing it out there that it's been done, and so maybe we'll see in the future. The other thing you can consider also, if you have really bad laryngeal collapse, you did the nose, you did the palate, you did the saccules, maybe you removed the tonsils, maybe not, and the dog still isn't doing that well, you have options for maybe a tie-back surgery. Again, is a laryngeal tie-back the way to go for really bad laryngeal collapse? I don't know. If it's a Hail Mary, if it's a life-saving measure, then I would say give it a shot, as long as the owners understand you're trying something that's not really reported, or at least we don't know for sure, documented whether or not it's actually efficacious. But it just gives you some ideas. because laryngeal collapse sucks. And it's sad to see these cases not do well after surgery, you know? So if you have some life-saving salvage options, then maybe it's a possibility. Okay, we're going to spend a fair amount of time on monitoring because I think telediagnostics, it's huge. It's already here, and it's only going to get bigger and bigger. And the reason for telediagnostics, which I would define that as being remote monitoring of the patient by collecting objective data that can then be assessed by a doctor or a nurse. Telediagnostics is already here, and it's phenomenal. We're all familiar with your standard monitoring where you're looking at the pet, listening to the pet, you're measuring and feeling stuff, but that involves touching the animal. And we all know that these dogs with respiratory crisis are very fragile. The more you mess with them, the more worked up they get. They're anxious as hell, right? And so they start to breathe harder and froth up, and then you've got to close the cage and give them a minute, and then go back in again, but you're trying to assess them. So that's where devices that are contactless or zero touch are coming into play. If we can monitor a patient from a distance, it's better for the pet, and it's less frustrating and scary for the staff. Because you need to interact with these animals, we also don't want to be a problem. So VetGuardian is a device that I absolutely love, and I'll show you some videos of this device as well. But essentially what it does is it uses thermography to assess certain patient parameters. And of course, Zomedica does make this device. So you've got body temperature, pulse rate, respiratory rate, all from a distance. There's nothing connected to the pet. It has a camera. This is an iPad showing one of the patients. You can see there's multiple animals on these devices, and it shows you the dog on live video, and it's got heart rate, respiratory rate, and body temperature all from a distance. You don't have to touch the animal for this. So you can figure out whether or not they're having any abnormalities from a distance. You can also switch the camera to a thermography setting. This is what it looks like from thermography behind a cage. And so those heat signals, the machine uses to convert to those vitals. And the reason for this, obviously, it helps the staff, helps the pet, it helps the client, helps the practice, and telediagnostics, I would say, it's no longer the future, it's already here. We've been doing it, and it's only to get more impressive over time. This is the actual device, IV pole, it comes with its own handle, and you can maneuver this thing however you want, and then point it at the pet, and then it'll start to measure. You have to set this device up ahead of time with whatever tablet or laptop you want to use, but stick it on the IV pole and then point it at the pet. And so this is what it's doing. This is a close-up again of the parameters. It's a very nice profile for these pets. And it's just showing that you can use it on different devices as well. There's another example of thermography. And so let's see. I'll see if this video can play. Hopefully it does. So this is going to be a splenectomy. So I don't have examples of brachycephalic surgery, but splenectomy is another type of case where these patients can be quite critical. This one was not critical. He's actually pre-medded. That's why he looks so weird. He's just doped up a little bit. That's all. He's fine. He's not a hemoabdomen or anything like that. But we have a splenic mass in this dog, and then there's the device. Now, I've tried different ways with this device. I've tried putting it on a stool, and I've tried putting it also on an IV pole, and this kind of depends on how big the pet is and what your space is around the cage. So that's Bronco. That's Bronco. He's ready for surgery. And so here we are in the OR. Just a quick showing you. There's Bronco. He's induced under anesthesia. We're shaving him. He's hanging out, getting ready. By the way, if you guys are performing surgery on older animals, be careful with the ties. I've had dogs that are arthritic. You tie them down too tight, they'll wake up quite badly lame, sometimes almost paralyzed. And it's obviously a preventable thing. They're going to be on their back anyway, so they have a bad spine. But at least be careful with the ties. So I'll leave these two pretty loosey-goosey. So after this video, I had them correct that because it's too tight. Just a little side note. And this is the spleen. Again, I know it's not brachycephalic disease, just an example. This is bronchial spleen. And the main mass is this one here. Just showing all those nodules. I don't know how much of these other ones are just splenic contraction or actual nodules, but that big one we found on ultrasound pre-op. So now this is Bronco in immediate post-operative recovery. back in his cage, and we're pointing the, we've got our standard devices here for blood pressure and things like that. And I just want to show you, don't do this, right? So I was putting in the cage to kind of see what it looked like, and it's definitely a better view. But imagine if the dog vomits or urinates on your expensive machinery, right? Then it's toast. So don't do that. I was doing it for the purposes of just playing with it and for the video. And there's Bronco looking at it, wondering what the hell's going on. So this is again, this is what you're not supposed to do. So this is like in the dog's cage. But I just wanted to show a close-up of the cool thermography settings, and then here's the measurements on Bronco. And so there. So I turned it from thermography to a normal camera. He's a black dog, so there's not much to see there. But just to show you that you can change from normal to thermal imaging, and then there's the monitoring. Again, for the purposes of brachycephalic surgery, it's great because it's a hands-free way of monitoring these pets. So again, don't do this. This is the purposes of the video. I just wanted to play with it and see. And there's Bronco recovering from surgery. We got some pain medication, a little bit dysphoric. And then there it is again. So there's the image. Just wanted you to see the contrast there and then the parameters. All right. And I think this is one more. So you can see it's his head, right? Again, don't do that. But it's just a cool looking image. I like the way that looks. So anyway, then those are the parameters you can measure. So whatever you can do to minimize stress on these animals, the ones that are especially unstable or prone to anxiety, these devices are going to be the way to go. So I highly recommend them. Quite useful. So complications of surgery. We're all familiar with the most common one, which is bronchopneumonia. Now, I have a bit of a soapbox when it comes to aspiration pneumonia, because we use that phrase a lot, without any evidence of actual aspiration. So sure, you can presume that if a dog came in for vomiting and now has pneumonia, probably aspiration, but do you actually see them aspirate? Probably not. If they vomit in their cage and you can see it's all over in their airway, or they vomit under anesthesia, okay, yeah, and then develops pneumonia, sure, you saw regurg. But in general, I'm very resistant to calling it aspiration pneumonia right off the bat. If I'm seeing that typical cranioventral distribution of pulmonary infiltrates in a dog that's brachycephalic, I'm calling it bronchopneumonia, and I'm leaving it there. So I'm very careful with the word aspiration. Just see, that's my own thing. You do what you want with that information. Laryngeal collapse is a mess. I mean, look at these arytenoids. They're just glued together, right? And all this edema. This is a mess. So laryngeal collapse is another problem, and then whether or not you need a tracheostomy to stabilize them depends on the situation and your comfort level. But these are just some of the bigger complications that you're dealing with. These dogs are prone to bronchopneumonia, obviously preoperatively, post-operatively, maybe lifelong because they're brachycephalics, and that they have comorbidities and they're more likely to have pneumonia. But pneumonia is always going to be a concern for them. Outcome, improvement. 85 to 100% improvement. Mortality is fairly low. Obviously, it's a wide range. It depends on what study you're looking at and how they categorize the dogs in terms of brachycephalic severity. Recovery considered excellent 6 months post-op, and 65% of dogs. Good, 25%. By 1 year, half of them are doing excellent. 50% are doing moderate. Poor, 2%. GI disease. Wide range, 66 to 91% resolution of GI disease. And then GI and respiratory treated, if you treat both conditions, you get a better outcome than you do if you only treat the respiratory conditions. So you want to treat the GI. So there's enough evidence, at least anecdotally, to say if I fix the respiratory problems, they will get better. If I try to tackle both issues, obviously they're going to be even better than that. And so I recommend treating with medications for these dogs if I have anything. So my regimen for these, I get them on antacids. Usually I'm using omeprazole. That's my go-to for brachycephalics. You can use famotidine if you want as well. But I have them basically on chronic, maybe lifelong antacids, depending on the dog's history. Is there a history of GI disease? Do my diagnostic shows any GI disease? And then when they go home, I tell the pet owner we're going to do a couple of weeks of antacids. Let's see how things go. I'm okay keeping them on it for months, years, or forever if needed. But I'm trying to avoid pneumonia. So I treat them with antacids. Now, as far as diet goes with these dogs, I treat them like a laryngeal collapse dog. I'll have them, the food a bit elevated, so they're not bending down. I also try to minimize the dust from the food, so I'll either use canned food, feed them meatballs or something, or if they're being fed kibble, add a little bit of water to the kibble so that there's less dust. The theory there with laryngeal collapse and other upper airway is the dust from eating the particulate matter can settle in the lower airway, making them more prone to bronchopneumonia. So that's the idea there. That's just what I do with these dogs. It's not necessarily a requirement, but I will feed them in that manner and have them on antacids post-operatively. These are prognostic factors that you can go over with the pet owners so they understand where they're at level of risk. The earlier the surgery, the better, and that makes sense. The longer you wait, the more secondary sequelae they have from this condition, right? So if you tackle them early, now the question is how early? If you have a brachycephalic, no clinical signs, they have stenotic nares, at what age do you repair them? So there's one paper that I'm aware of that I think looked at 6 weeks of age, and they did great. That's really young. That's really young. So I don't know. I've never done them that young. As a surgeon, I have a biased population of dogs that are really messed up that come and see me. So I don't get to see the happy, healthy puppies that are looking for a consult with this. But how early, I don't really know. That paper's a bit extreme, and hopefully we'll see more literature in the future about it. I would probably say for most folks, if you're going to spay or neuter them, maybe do it at that time. If you're comfortable and the pet owner's up for it, and the dog obviously has this disease, maybe at the time of spay neuter, go ahead and do it. I don't think you'll lose that much time if you wait until they're about 6 months or a year of age whenever you're spaying and neutering, but maybe combine it with that. Younger dogs might have a better prognosis. It's hard to say. Some literature shows the opposite, so I'm not really too clear on that, but it would make sense that younger dogs have better prognosis than older dogs. Laryngeal collapse, we know what's the problem. Hypoplastic trachea, bronchopneumonia, any concurrent airway disease, those all worsen the prognosis. GI disease, of course, worsens the prognosis, presumably due to aspiration pneumonia or bronchopneumonia in general. And then now in the literature, they're using the phrase traditional multi-level surgery. So traditional multi-level surgery means you fix whatever's fixable, all the things, right? And they've been shown that if you fix all the things, the outcome is better than only fixing a couple of the diseases that these dogs have. That makes sense, that's intuitive, but then it brings back my original quote of, do you remove the saccules or not? Because that is an abnormality, and I'm trying to stay away from doing it because I'm not really sure it's that impressive. But just so you know, in case you look in the literature, traditional multi-level surgery is the preferred method for prognosis. We need more studies to show this or disprove it, but just wanted to make you aware of it. That's the language that's being used now in the literature. So key points. Client communication is very important. And the main thing I will tell you is the repairable versus non-repairable. It helps keep the diseases in the client's mind straightforward, even though we know it's a complex disease. So repairable versus irreparable disease is how I'm setting these owners up so they understand if the outcome is suboptimal, that it's not anyone's fault, this is what the dog's got going on. Keep in mind the GI disease, dive into those histories, figure out if they have a history of chronic GI, really probe the owners and see, because some owners initially will say, no, he's fine. Then when you question further about flatulence, stomach sounds, regurgitation, burping, things like that, they'll sort of say, oh, well, yeah, he does actually, every couple of months or whatever, something, right? So if you see it, or if they tell you about it, then at least consider it. And then you want to tailor the case, the surgery compared to the case. So that traditional multi-level surgery paper, again, we'll see more papers reinforce that thought, but I will still advocate for fixing what needs to be fixed for these dogs when you diagnose it at the time. You don't want to have just a cookie cutter approach to this. You want to be able to tailor the surgery to whatever the dog needs. And that's what I have for you. Thank you again, Zomedica, for sponsoring this. This is my contact information. If anybody wants to reach out to me, you're welcome to. That QR code is from my telehealth company, VetTriage. We have a booth as well. And I'll take any questions or comments you folks have.
I was always wondering,
I can't hear.
So what's the landmarks? for the piece of palate dissection?
So the question is, if you're going to resect the palate, what are your landmarks? Okay, so what you're looking for is the end result. You want the palate, and again, it's not a good picture, but you want the palate to just barely touch the tip of the epiglottis. That's what you're looking for. As far as your landmarks for that, usually we're looking at the palatopharyngeal arch, right? So from this junction to this junction. Typically, your cut, or your planned cut, is going to be from the edges of the bottom of the palatopharyngeal arch, taking into account where your new palate is going to be in reference to the epiglottis. So you're going usually straight across, although sometimes I have done like a semicircle. You're going straight across from one edge to the other alongside the palatopharyngeal arch with the goal that the epiglottis tip is just about touching the new palate that you're going to create. I do, when I've trained interns and residents for this procedure, I tell them this is more of an art than it is a science. You know, it takes time to practice this. And again, I do recommend a cadaver if you're going to dive into this world, right? But it's no two cases are the same when I repair them. But that's my general guidelines for them.
And also, sorry, one
Yeah,
question. Laryngeal edema after surgery. How do you do it?
Say it one more time.
Laryngeal edema.
Laryngeal edema?
Yeah.
So the question is, how do you deal with laryngeal edema after surgery? Medical management is going to be key. That's where steroids really come into play. I love steroids for this. And so I will give the steroids either at the time of induction, if I know they already have laryngeal edema, or I'll give it post-operative if they're having complications, and then I look at the upper airway and I see laryngeal edema, I'm giving them steroids. And usually it's either going to be depomedrol or dexamethasone, specifically what I'm using, depending on what's available in the hospital. So I like steroids. If I don't see an improvement in 20, 30 minutes, I'm okay giving them another round of steroids. It's a lot, and you want to cover them with GI protectants in the hospital. But if I don't see a response in 20, 30 minutes, especially if it's life-threatening, I give them another injection of steroids. And then when they're able to eat again, depending on the timeline of things and did they receive steroids or not, some sort of oral anti-inflammatory is great. Again, you have to keep it into account. They have pre-existing gastrointestinal disease. The steroids or non-steroidal anti-inflammatories may make the GI disease worse. So have them protected. If you really want to do anti-inflammatories, have them on antacids and motility drugs and anti-nausea. But that's my go-to. It's going to be steroids for the immediate response, and then maybe oral anti-inflammatories of some kind to go home with. So, thank you. Any other questions?
At what point would you consider permanent tracheostomy for organs like your collapse?
So the question is, at what point would you consider a permanent tracheostomy for these dogs? So temporary tracheostomy is obvious, right? You're using it in the perioperative period to stabilize the pet and control the airway. Permanent tracheostomies are those cases where I've exhausted all my surgical options and they're still having issues. And these are always, like you said, dogs with laryngeal collapse. They have really severe laryngeal collapse that no other measures have worked. I've fixed all the routine things. I've maybe even done a partial arytenoidectomy. Maybe I've done a tieback and an arytenoidectomy on the same side. And then they're still coming back with, either they're not leaving the hospital because they're just in constant respiratory distress, or they're coming back to me frequently for upper respiratory crises. That's when you'd consider a permanent trach. The problem with permanent trach is, number one, most dogs that are receiving it are going to be like English bulldogs. They have really thick necks, lots of skin folds, and they make a ton of mucus in the lower airway. They are a pain in the ass to manage with a tracheostomy. It is a nightmare. So number two, the pet owner, the client, has to be up for that challenge. It is a constant nursing care situation with these dogs, and they can run into a mucus plug crisis at any time with a permanent tracheostomy. It's awful, but if it's the right case that needs it to survive, and it's the right pet owner, then that's the time to do it. Any other questions? Yes.
So you do only tieback, or you do ablation of the cartilage?
Ablation of the what?
For the cartilage, for the laryngeal collapse. Only tieback is your technique, or?
Yeah. So what's my technique? What's my technique for laryngeal collapse? So I would say, because the answer is there is no technique for this. It's a matter of whatever you need to do to make the dog feel better, right? So you can either consider doing a partial retinoidectomy. So you remove a portion of the retinoid. You only do it on one side. It's only unilateral. The chance of pneumonia with bilateral retinoidectomy is 90%. It's like 50% if you do only one side. So it's still terrible. But a partial retinoidectomy is an option. And usually what I'm doing is I fix all the routine things. They're not doing well. I induce them again. Partial retinoidectomy. They're still not doing well. Then maybe a tieback. Yeah. And then what? Yes, the question is your first choice a partial retinoidectomy and then a tieback? Yeah, it is. And the reason for that, there's no data to support that. That's just my own experiences. Is a retinoidectomy is a very quick procedure. You're in and out in a second. The tieback's a bit more involved. And there's more evidence of using this for laryngeal disease than there is the tieback outside of laryngeal paralysis. So I go for this first. But again, remember, there's no rules for this. This is me in a really crappy case. Yeah. So, but partial retinoidectomy first, and then tieback after that if needed. What do you use for the retinoidectomy? So what do you use for retinoidectomy? So I'm again a bit spoiled. I'm using LigaSure for that. Yeah, LigaSure. You have to use a small one. There's but I would say though that the studies are very convincing that laser is maybe the best way to go with this stuff. But I don't use laser myself, so. So they make really small LigaSures that you can use for this. Yeah. The problem with the retinoidectomies, for folks who are not familiar with it, is laryngeal webbing is a major issue. They'll form scar tissue in the airway, and then again, now you have a recurrence of the upper airway obstruction. So that's a big one, and of course pneumonia. The predisposition for pneumonia is a concern as well. Any other questions? Okay, thank you everybody. Appreciate it, thank you.